Cancer Treatment Response Evaluation. Dr. Ahmed Osman, Assistant Professor of Radiology, Ain Shams University.
Hello everybody, it's my pleasure to be with you today. First of all, thank you very much for the organizing committee for their invitation to me to be with you today. We will talk about the imaging of non-small cell lung cancer after staging and after screening. What's our role as a radiologist during follow-up of the patients and how we can assess the treatment response. After screening and after adequate staging of the patient with non-small cell cancer, they have only options in the form of surgical treatment, chemotherapy, radiotherapy, or concurrent chemo and radiotherapy. These depend on, as clearly explained in the previous two talks, very nice talks by my professors, depending on the surgical staging, 1, 2, 3, and 4. And this is also very important according to the percent 5-year survival rates. As we said, and we see the best outcome clearly observed in patients with surgical staging 1 and 2, and slightly and progressively decrease in 5-year survival rates in stages 3 and 4. Regarding stage 1 and 2 and 3A, they have the option for surgical treatment alone or even with chemo and radiotherapy or adjuvant chemotherapy. Stage 3B, unfortunately, and stage 4, they have no option for surgical treatment, and the treatment in the form of radiotherapy or concurrent chemo and radiotherapy, and even in stage 4, they just palliative or symptomatic treatments. Regarding the follow-up of the resected tumors, usually it will be in the form of chest X-ray during the first 6 weeks, just for the immediate post-operative complication, followed by post-contrast CT done after 3 months from the operation, and then repeated every 6 months for the first 2 years, and then annually for the another 3 years to complete 5-year continuous follow-up. And this is very important to detect any local recurrence and distant metastasis, which is has a very low incidence, but it can occur. Most of the literatures discussing about 10 to 15% local recurrence in the resected patient with non-small cell lung cancer, and also to detect any new primary lung cancer, which is rare but can occur in our patients. This is a case in our archiving in Ain Shams University for a case with squamous adenocarcinoma, underwent surgical resection for upper lobe lesion, upper lobectomy. During her follow-up, we discovered total left lower lung lobe collapse with a central tumoral lesion obstructing the left main bronchus and extending into the lumen of the bronchus. And this is her visual bronchoscopy, confirming the presence of a fungating mass lesion into the left main bronchus, causing its total occlusion with total collapse of the left lower lobe. And this is the direct bronchoscope, and the biopsy confirmed the recurrence. This is another similar case published in Cancer Imaging Journal for almost the same situation. What about the non-resected tumors? How we can assess the tumor response evaluation? Usually these category of patients are followed by either CT, which is more common, almost every 3 months, and these depend on the clinical situation of the patient. the tumor staging, and the type of treatment, either chemo, radio, concurrent chemo and radio, or even immunotherapy. Sometimes we need PET-CT in a special conditions when there is some sort of clinical radiological mismatch, or even for a restaging after tumor response for the treatment, and to induce another line of treatment for some cases. Usually during follow-up, either using CT or PET-CT images, as a radiologist, we can use what's called RECIST or persist criteria. And this is the rule how we can, please. And this is the way how we can use the RECIST or persist criteria. We must select what's called target lesions and non-target lesions. The target lesions must not exceeding 5 for one case, and must not more than 2 lesions in one organ. For example, as we discussed non-small cell lung cancer in our talk today, we can select, of course, the mass itself, but in condition the mass must be exceeding 10 millimeter in its long axis. As our Prof told us, the mass must be measured along its long axis in long window, so we can use it as one of the target lesions. Lymph nodes, if we put it as a target lesions, must not exceeding 2 in number, and the lymph nodes must exceeding 15 millimeter in their short axis and long axis. Our reference is short axis. In RECIST or persist criteria, they must exceeding 15 millimeter in short axis, and we must only use 2 lymph nodes in the lung, and of course we use the largest 2. We can add more lesions as suprarenal, pulmonary nodules, hepatic, cerebral, and lytic soft tissue mass lesions, which is measurable lesion. Lytic soft tissue, we must to have a soft tissue component can be easily measurable to be put as a target lesions. Regarding the non-target lesions, we can use the measurable lesions, which is not included in the previously discussed target lesions, as mass lesions, but their long axis less than 10 millimeters. The lymph nodes with short axis ranging between 10 to 12 millimeters. Any measurable lesions not including in the target lesions can include it in the non-target lesions. Non-measurable lesions as effusion, ascites, bony lesions, either lytic or sclerotic, and lymphangitis carcinomatosis. We can put also lesions that query to be metastasis, but not definitely diagnosed as metastatic lesions. This is the final judgment after we consider the target and non-target lesion. Either there is, during follow-up, there is complete response with disappearance of all target and non-target lesions, or regarding the persist, there is no FTG uptake or uptake less than the liver, which is our reference in PET-CT imaging. Partial response if the sum of the target lesion decreased by more than 30%, or the SUV the same regarding the persist. Progressive disease if there is progression of the sum of the target lesions more than 20%. Stable response if there is decrease but not reaching to 30%, or increase but not reaching to 20%, it will be considered as a stable disease. Of course, it is not simple as we see, but this is a complete formula regarding the judgment of the target lesions and non-target lesions, and post together lead us to an overall response, either complete response, partial response, progressive disease, or a stable disease. Of course, RECIST and persist both considered any de novo lesions or any new lesions. It will be a progressive disease, whatever the response regarding the target and non-target lesions. There is some tricks during using RECIST or persist criteria. These are 2 examples of our tricks. During follow-up, the sum of the target lesion was initially 3 centimeters. After the first follow-up, the sum of the target lesion dropped to 1 centimeter. This, according to RECIST criteria, it will be partial response disease, okay? Then after further follow-up, the 1 centimeter increased slightly to 1.3 centimeter. According to our rules in RECIST criteria, it will be a progressive disease because there is an increase more than 30%. Further follow-up, 1.3 developed to progress to 1.6. 1.6 compared to 1.3, this will be a stable disease, and this is a wrong comparison, because if we follow up using RECIST criteria, we must go back to the best and the smallest sum of the target lesion, which is called nadir level. خلاص, it's okay. And so 1.6 must be compared to the best response, which was in our case 1 centimeter. And in this case, this is of course a progressive disease, not a stable disease, which need more action regarding the oncologist. And this is how our judgment will even change the line of treatment in some cases. So we must take care of this point, for example. Another example, if there is progressive or progressive decrease regarding the number or the sum of the target lesion, if you are initially started with 10 centimeter as a sum of the target lesion, then after follow-up it will be 8. This will be a stable disease. 8 develop after further follow-up to be 6. This will be a stable disease, and this is unfortunately wrong judgment. And if there is a progressive decrease regarding the size, our baseline will be the nadir level, not the smallest. And in this case, our judgment will be a partial response disease, which indicates this is a good treatment response, not only a stable disease. Another track, which is very important to know, the line of treatment received by the patient, either chemotherapy or radiotherapy, or even in our case, immunotherapy. Immunotherapy has some track regarding the radiologist. They have an incidence up to 5% to develop what's called pseudo-progression, especially during the first follow-up. The tumor size increase, and this may be explained by the lag, which developed after initiation of the immunotherapy to develop its effect. During this period, the tumor still increase in size, and some theory about the accumulation of the immune-mediated cells and immune-mediated response inside the site of the tumor, and this may lead to a pseudo-progression of the tumor. This can be discovered by the discussion with the oncologist, which is alarming us about the type of the treatment, immunotherapy, and about the good response clinically. Clinically, the patient show a good response for the immunotherapy. This is against the radiological image, so we must suspect in such case what's called pseudo-progression. This is another example for a patient receiving immunotherapy with de novo development of new nodules in the left lung, which of course, if we don't know he received immunotherapy, it will be considered as a de novo lesions, as a progressive disease, and this may lead to or may direct the oncologist to change their line of treatment. But if we have a background of immunotherapy and a discussion with the oncologist about the clinical improvement, this may hold our decision to suspect this may be a pseudo-progressive disease. That's why RECIST modify their criteria to immune RECIST criteria, and they add the de novo lesions into the sum of the target lesions and decide we put a progressive disease criteria if the sum of both target lesions and the de novo lesions as our aim to judge the response of the treatment. Another track, if there is a clinical and radiological mismatch between the oncologist and radiologist response, if we use the CT, usually we can go to the PET CT to assess the activity of the tumor, not only the mass size of the lesion, such as in this case, CT show no sizable change in the size of the mass, and regarding the recessed, it was a stable disease, but the reduction in SUV uptake was according to PAARS as a partial response. And this is another example, but in opposite direction. There is a stable disease by CT criteria. And PET-CT, there was an increase in the SUV uptake of the tumor and considered a progressive disease, which was compatible with the clinical condition of the patients. Also, regarding another line of treatment, which is radiotherapy, we must be familiar with the radiation-induced lung disease, and we must take a full information about the dose of radiation, the port of radiation, direction of radiation, to can diagnose its effect, especially if our patient receive radiation dose more than 40, they have a high incidence to develop what's called radiation-induced lung disease, which is usually early, can appear in the form of ground glass opacities, consolidations, radiation-induced pneumonitis, and after repeated follow-up, our patient developed fibrosis. This is another example for radiation-induced lung disease. There is bronchogenic non-small cell lung cancer in the left lower loop. After receiving radiation, the mass show partial response and decrease in size, but developed the nearby lung parenchyma developed fibrosis. Some areas of fibrosis, ground glassing. After more further follow-up, extensive fibrosis developed with almost complete disappearance of the mass and minimal traction and bronchiectasis as sequelae of the fibrosis. This is almost similar condition as we previously seen in the previous slide. This is another example for complete response and disappearance of the mass with development of fibrosis, traction and bronchiectasis as sequelae of radiation. Another and last our track today about radiation-induced fibrosis. After repeated follow-up of such case, the fibrosis increase in size and develop to a lesser extent a convex border, which is not the behavior of fibrosis, which usually developed concave border and some sort of traction and bronchiectasis. So development of such convex border may alarm us about the presence of underlying local recurrence, and this is a strong indication for PET-CT. Finally, for treatment response and follow-up with the patient, it's not one-man show scenario. We must have an MTT for our patients, and we must have a good communication with the oncologist and thoracic clinician, chest clinician, and even the thoracic surgery for better judgment of the treatment response. And this is our weekly meeting in Ain Shams University, MTT meeting, including the oncology team, thoracic surgery, chest and radiology every week to discuss our cases. Thanks a lot.
Thank you, Dr. Ahmed, for the very informative lecture and clarifying lots of points related to treatment response. Now I'd like to welcome our distinguished guest from France, Professor Marie-Pierre Revel, Head of Radiology Department, Cochin Hospital, University of Paris.